excited to present my first grand rounds to you today. For those of you who I haven't met, my name is Ariel, and I'm one of the PGY3s in the FR program. I'm going to thank everyone who helped me put this talk together at the end, but I would like to acknowledge first my supervisor, Dr. Deb Eagles, without whose immense knowledge of the topic and passion for it, I'm not sure I would have forged ahead with this. I have a lovely mic, and I've practiced in a loud voice, but loud voice is relative, so friends at the back, if you can't hear me, please let me know. So we'll set things up with a quick poll. So hands up, how many of you have taken care of an elderly patient above 80 with a fall in the past week? Okay, everyone. And keep your hands up if you were totally comfortable with your falls assessment and you felt like you tied up all the loose ends and you did a bang-up job. Dr. Clark. Okay, so not everyone at once. I mean, we know that weakness and falls in the elderly are probably not anyone's chief complaint because they're complicated. And sometimes, as emerge docs, we like a little bit of instant gratification, right? But we all know that the silver tide is coming, and we're lucky here to have such an excellent GEM team who does great assessments for us. But as we know, there are some times when GEM's not available, or as trainees, some of us will go to places where GEM is never available. And even before we refer someone to GEM, I'm hoping to convince you today that there are some things we can do to finesse our assessment of the older patient in the ED. So for objectives today, we'll first learn why we actually need to know a decent amount of geriatric medicine in today's emergency department. Next, we're going to learn what frailty is as a concept and why you need to know about it in the emerge. We'll talk about some evidence-based tools to improve our falls assessments. And lastly, we'll learn some strategies to manage pain better in our older patients. So we'll start with some definitions. What is old anyways? We're always told that age is just a number, as I think that Harriet, our 92-year-old marathoner on the left, and Robert, our 105-year-old cyclist on the right, could attest to. When you look at the literature, most of the literature refers to patients who are 65 and older as geriatric. And some of you will be really upset with me to learn that the WHO actually uses 60 and above as geriatric. I'm sorry, I didn't make it up. But for the purposes of today's talk, most of the statistics that I'll give you will be for patients 65 and older. Really though, for I think many of the issues we're talking about today, we're thinking in our heads about patients who are 80 and older when it comes to frailty and to falls. So everybody knows that the population is aging, and rapidly. Currently, the Canadian population is comprised of adults who are 65 and older, 14%. But that number is expected to increase to 25% within the next 10 to 15 years. And it might already feel to you like every patient that we see in our OBS or our emergent care departments is elderly, but that's actually not the case. So with data from our corporate ED managers here at the Civic, we know that only 30% of the patients we see overall in our emergent department here are 65 or older. But the problem here is twofold. So one is that I just told you that this population is expected to rapidly increase over the next 10 to 15 years. And the second problem is that these patients are at a disproportionately high risk of adverse outcomes. So we already know to be intuitively nervous about sending an older patient home without a really careful think through of the issues. And the literature here backs us up. So in a large study by Drs. Aminzadeh and Dr. Dalziel, the latter of whom is one of our own geriatricians here, we know that of elderly patients who are seen in the ED, 1 in 3 will be back in the ED within 3 months, most of these within the first month, and you know what that means. And 1 in 10 will have died at the 3-month mark. And beyond bounce backs and a high mortality in our outpatients, what we do in the ED matters. So I think that what we do prior to referral of a patient for admission matters for our pain outcomes, it matters for resource utilization, and for goals of care planning. Before we really dive into the literature, I'm going to warn you that geriatric medicine, in case you weren't already aware, is difficult. So it doesn't ever have easy, neat solutions. And partially because of this, the literature that we have, especially in the ED for these issues, is lacking. And I'll mention places where we have ED studies and where we have no ED studies and we have to extrapolate from outpatient literature. But I don't think that these difficulties should discourage us from diving in. So I really like this quote from Dr. Kenneth Rockwood, who is one of the geriatricians at Dalhousie. He says, "Geriatric medicine that does not embrace complexity is geriatric medicine done badly." So with that, let's start with a case that I'm sure none of you have seen in the past week. This is an 87-year-old lady who's from home with her husband. She slips, it's still a bit icy, she slips on her driveway and has a foosh. And this is her x-ray. So pretty typical, right? She's casted, she's sent home with orthopedics follow-up, and is told to take Tylenol for PRNs. So that's all fine. And then 8 days later, you get this dreaded email in your inbox. She falls again, and she's back with a hip fracture. And all things considered, her postoperative outcome is reasonable, and she's discharged to rehab a week after her admission. So as we go through the talk, I want us to think, for this patient who is so much like many of the patients that we see, first, was this outcome predictable? And if we could have predicted it, was it preventable? And lastly, keeping those things in mind, what can we do for future patients who are going to be exactly like this? So we'll start with our first big content block, which is frailty. Now, I think that most people think of frailty in the context of a little old lady, like maybe me and add 60 years. But what's frailty in the literature? And why does it matter to us in the ED? So in the early 2000s, the geriatric literature started to struggle with a definition of what frailty actually is. There wasn't, and there still isn't, any gold standard definition for frailty. So some experts think that it's simply a physical phenotype of vulnerability to potential stressors. But others think that it also encompasses social isolation and psychological vulnerability as well. It's basically as simple as this. Now, don't worry, we're not going to actually go through this, but this is a representative diagram from the seminal Freed study on frailty that I'll talk to you shortly about. It's identifying, though, the complexity of what frailty is. So it's an interplay of factors in the context of aging that lead to decreased body reserve. And what I want to make really clear is that frailty is not normal aging. So that's a really unfair assumption, actually, of our geriatric population. Frail patients are really only a subset of the patients that we see, even in the ED. And this is where the concept of homeostenosis comes in. So everyone knows what homeostasis is. Homeostenosis is the idea that as we age, the normal body mechanisms that would restore homeostasis in a patient will decrease in their effectiveness. So an illness or injury that a younger person might withstand with no issue whatsoever can be an insult that an older person physiologically cannot recover from. And I think we see this all the time, maybe without recognizing it for the technical term, but frail patients are at an even higher risk of this phenomenon. So I already told you that there's no widely accepted definition of frailty, but most definitions include some component of these factors. So this is the Freed definition, which is the best known and probably best studied definition of frailty. And they focused on 5 factors: weakness, which they quantified with decreased grip strength, slow gait, low levels of physical activity, self-reported exhaustion, and unintentional weight loss. And just as a side note on the last one, you can actually be obese and be frail. So in the very large Women's Health and Aging study, frailty indicators were higher in obese women, except for the last one, than in normal weight women. And again, frail patients are only a subset of our population. So in outpatient studies, frail patients make up about 7 to 10% of the population. And in our ED populations, still most studies only classify frail patients at about 10 to 20%. Okay, so now that you know a bit about what frailty is, why does it actually matter to us? So Freed and her colleagues assessed 5,300 US patients in the early 2000s, and they classified them as frail, pre-frail, or not frail. So by those 5 factors that I talked to you about, to be frail you needed 3 of the 5, pre-frail you needed 1 or 2, and not frail you needed obviously 0. And they followed the patients for 3 and 7 years, and what they were looking at was function, falls, cognition, and mortality. And when they applied the criteria, what they found was that independent of comorbidities, and they did an adjusted analysis for age, for sex, and for common disease processes, frailty itself was an independent predictor of falls, disability, hospitalization, and death. So these are their Kaplan-Meier curves, and the non-frail patients are the top line, and the frail patients are the bottom line. And you can see how the survival curves just separate right out. So at the 3-year mark, mortality was 18% in the frail cohort versus 3% for the non-frail. and that difference increased even more at 7 years, where mortality was 43% for the frail patients versus 12% for the non-frail. So we know from the Freed study that frail patients have really poor outcomes, and this has been replicated in other studies as well. Frailty has been associated in separate studies with an increased risk of falls, an increased risk as expected of hip fracture, a higher risk of functional decline, and high mortality. And I just wanted to highlight the study that I've labeled in the third line as SETI. So this study by Dr. Provencher is part of the body of work being done by the Canadian Emergency Department's TEAM initiative, which is a collaboration among several centres in Canada that aims to identify the factors that lead to functional decline among seniors who present with minor trauma. So these are truly seniors who might be seen in our urgent care areas, who have falls, who have lacerations, who have fractures not requiring admission. And Dr. Perry and Dr. Eagles have been very involved with SETI, and I'll talk about some of their work later on. In this particular study, though, that was based on the SETI data, patients who were classified as frail were more at risk for functional decline than non-frail patients, even, like I said, after they presented with minor injuries that did not require admission. So we know what frailty is, and we know it's associated with adverse outcomes. And now, as with many of the other things that we have, we'd like to quantify it, right? So on the left are some of the many acronyms for tools that were either originally derived to assess frailty, or tools that were co-opted and used as a secondary measure to assess frailty. We're not going to talk about all of them, don't worry. The first one that I want to discuss, though, is the Clinical Frailty Scale. So this is a really nice tool designed by our Canadian colleagues out east, including Dr. Rockwood. This is a pictorial version. So originally it was designed as a 7-point scale, and they've added to the very severely frail and the terminally ill on the very right there. The CFS has been used in some of our own ED-based studies, although it originally was validated in outpatient studies. And the only issue I see with it, it's really nice, and obviously it's easy to use the pictorial version, but the only issue I see with it is that many of the patients that we see in the ED are at all points in their assessment in the category 8, or at least they look like that. So I wanted to show you this scale, and if you do read some of the frailty studies, you may recognize this scale, but we're going to talk about two other tools today, the ISAR and the SOF. So the SOF is the study of osteoporotic fractures frailty index. And Ensred and colleagues compared the Freed criteria, which, if you'll remember, is that 5-component scale, to their SOF index, which was a simpler 3-component index that they prospectively derived in outpatients. So their 3 criteria were weight loss greater than 5% over 2 years, so not very much. Weakness is quantified by inability to rise from a chair 5 times without the use of the arms, and a subjective endorsement of decreased energy levels. And to be frail in their criteria, you needed 2 of the 3 criteria. And what they found was that their scale performed as well as the Freed criteria for predicting adverse outcomes among patients who were classified as frail. And the SOF criteria have been used in our ED as well, especially in the studies that have been performed in our own center. So in this study by Dr. Sirois and colleagues, they assessed patients who presented with minor trauma, and what they found was that the SOF index performed fairly well for predicting functional decline. Now, the last tool I want to talk about is the ISAR, or the Identification of Seniors at Risk tool. Again, a nice Canadian tool. So this was designed by Dr. Jane McCusker and her colleagues out of Montreal. And what you should know is that it was originally designed to predict adverse health outcomes among older ED patients, and not specifically to detect frailty. The components of the ISAR are a need for regular help at home, a need for increased help at baseline prior to ED visit, hospitalization in the past 6 months, vision problems, serious memory problems, and 3 or more medications per day. And 2 of these 6 constitute a positive screen. So again, I mentioned that some of the tools have been co-opted to assess frailty, even if they weren't originally designed for that. Salvi and colleagues applied it to a group of older Italian patients, and they looked for its ability to pick up frailty and predict adverse outcomes. And they found that it had quite good sensitivity, 94%, to pick up frailty. Although it wasn't originally designed for that purpose, they implicated that it could be used to detect frailty and predict adverse outcomes among ED patients. But more importantly, I'm mentioning it to you because we already have a modified ISAR on our chart already. So I don't know if this is something that any of you recognize. It's on page 3 of our nursing assessments. and it's labeled, instead of ISAR, it's labeled as discharge planning. So very similar, slightly modified, but several of the questions are almost identical to the original ISAR. And the idea is that when you write nursing charting reviewed and you see this on the chart, a positive ISAR might be another potential flag for you to involve GEM if it's appropriate. And we'll talk at the end about what constitutes an appropriate GEM referral. Okay, so we talked about 3 different screening tools in the ED. And if I were to recommend one, I probably would recommend the SOF. Oh, we have some issues. There you go. So it's simple. It just has 3 components. So as a recall, it deals with the subjective exhaustion, objective weakness, and weight loss. And it's already been studied and used in our ED. One thing that's clear, though, from multiple studies is that older patients are not good at estimating their own frailty. So if you ask an older patient if they walk slowly or if they're unsteady, what's been shown in the studies is that they way overestimate their own strength. Which means that if you're going to use a walk test as one of your tools to assess frailty, so i.e. decreased gait speed, you actually need to watch that walk test instead of just trusting the patient to tell you that they're doing just fine. And one thing I also find interesting is that we have so many risk tools where experienced clinician gestalt is sometimes about as good as those risk tools. Frailty is not one of those cases. So ED clinicians are not good at estimating frailty, which really speaks to frailty being an underappreciated condition in the ED. And I think it is important for us to recognize for a few reasons. So ideally, if we were to pick up patients who are pre-frail or frail, we'd be able to refer them and intervene with the right resources. And the last reason that I think it's important to pick up frailty in the ED is for prognostication and goals of care planning. So before we move on, I just want to talk about the PATH program out of, again, Dalhousie. So this is what I found to be a really interesting program out of Dalhousie from their geriatrics department. They recruited patients who were frail, and they put them through a structured 3-visit assessment. So patients were assessed, and then they were given more information about frailty and what it actually means. And on the last visit, they had discussions regarding goals of care making over time, goals of care decision making. And so they talked about really important questions that we often deal with in the ED, like should we be providing IV hydration at the end of life? And should we treat aspiration pneumonia with antibiotics? What they found was that when patients were provided with information about frailty and about the outcomes associated with frailty, they overwhelmingly opted to decline invasive procedures and surgeries. This program was so successful that it's now an established clinic in Nova Scotia, and they've released, you can go online and they've released evidence-based guidelines on treatments that are inappropriate for frail patients. For example, patients who are frail require less strict blood pressure targets even than the rest of our elderly cohort. They don't need as strict HbA1c targets, and they probably don't need that statin. Now, obviously, this kind of 3-visit structured approach isn't feasible in our ED, but I do think that with an aging population and an obvious disconnect at present between the way that patients say they would like to die and the way that they do die in our hospitals, this kind of approach has a lot of potential in the future. We need to start recognizing frailty and the types of treatments that might be inappropriate based on frailty. So in terms of a summary for this section, I'm hoping that you'll recognize that frailty is a distinct syndrome that has high morbidity and mortality, and that it's important to recognize in the emergency department, both for intervening upon and for prognostication in the future. And that lastly, if you want to use a walk test as a measure of slow gait speed in your patients, you actually need to watch them walk. Which brings us to our next section. Okay, so falls in older patients are a sentinel event in their lives, and between 20 and 30% of seniors fall each year in Canada. And the rates of these falls and fall-related mortality continue to rise. We see most of these patients in our EDs. So this graph from Public Health Canada indicates that 2 out of every 3 patients who have a fall will be assessed in our EDs. And the impact on resources is huge. So direct and indirect costs from falls rank about $6 billion per year in terms of costs. And what you should know, and I didn't know prior to this presentation, is that we have the worst fall rate in the province. So the Champlain-Lynn has the highest fall-related hospitalization rate in the province and the second highest ED visit rate for falls in the province. Now, obviously, the Champlain-Lynn is taking this really seriously, and this prompted a comprehensive falls prevention strategy in the community. So in the community, elderly patients are supposed to be screened on a yearly basis for falls, including with the staying independent checklist, which I'll talk about after. But our ED-based falls assessment differs a bit, right? So in terms of our ED-based falls assessment, the first question that you should ask yourself is, if this patient was 20 years old, would they have fallen? I think a lot of the time we ascribe falls to pure mechanical causes, like the patient tripped, but the reality is that most falls are multifactorial, and there may be some modifiable causes that it's our job to start unearthing. So again, there's unfortunately minimal research on falls predictors actually in ED-based patients. I'll talk about 3 studies that are informative, though, to our history taking in the elderly falls patient. So in the first study, Carpenter and colleagues looked at risk factors for falls at 6 months in ED patients who ended up discharged from the ED. Their 6-month fall rate was 14%, which is in line with our Canadian averages. And what they found, interestingly, was that the traditional risk factors that had been documented in outpatient studies as fall risks, for example, vision problems and age, were actually not associated with falls in this originally ED-based population. Instead, their top risk factors for falls were non-healing foot sores, history of a fall, self-reported depression, and an inability to cut one's toenails. And I thought the last one sounded a bit funny too, but if you consider the mobility and the dexterity required to perform foot self-care, it makes more sense. And then Tiedemann and colleagues tried to derive a simple falls risk tool in the ED that was only based on history. So they tested the ability of a 2-item screen, which dealt with falls 2 or more in the past year and being on 6 or more medications to predict fall risk at 6 months. And they thought that their tool performed fairly well with an area under the curve of 0.8. And then most recently in a meta-analysis again by Carpenter, they confirmed their previous findings. So in the ED, depression actually was the strongest predictor of 6-month falls with a positive likelihood ratio of 6.6, and non-healing foot sores has a positive likelihood ratio of 3.2. Okay, so that's a lot of information, but to distill it down, in our ED-based studies, the strongest or the most consistent risk factors for falls are a history of falls, a history of depression, and poor self-care. So now I want to talk about some useful physical exam tools and testing in your ED falls patient. Okay, so orthostatic vitals have gotten a bad rap over the past several years. You've probably heard that lots of people, young and old, have orthostatic drops at baseline that are asymptomatic, and you've probably also heard about how terrible the studies that looked at orthostatic vitals and blood loss were in terms of sensitivity and specificity. And that's all fine. But when it comes to your elderly ED falls patient, I'm hoping to convince you that orthostatic vitals are an easy and actually important test to complete. So I have to admit that orthostatic vital changes in the elderly are prevalent at baseline. So in outpatients, the prevalence of orthostatic hypotension is about 5 to 30%. But in hospitalized elderly patients, this is dramatically increased, up to 70% in some studies. And many of the medications that our patients are on are culprits. So there are lots of studies that demonstrate an association between antidepressants, anticholinergics, and benzodiazepines and orthostatic drops, likely because of the failure of an autonomic response to changes in volume withstanding. The literature on antihypertensives is a little bit more confusing. So earlier studies in the 90s demonstrated a clear association between antihypertensives and orthostatic hypotension. But more recent studies in, I have to admit, outpatient, well-geriatric populations have shown that there's not as clear an association between the antihypertensive treatment and the orthostatic hypotension. But just as another reminder, so our Canadian Hypertension Education Program guidelines, our CHEP guidelines, would recommend that you only target a systolic blood pressure of 150 in our elderly patients who are on antihypertensives. So we're not looking for anywhere close to that ideal BP of 120 in this age group. And what we do know is that in community-dwelling elderly patients, blood pressure targets that are lower than this number are associated with higher falls risk. Okay, but what you still want to know is whether orthostatic hypotension is associated with falls in the elderly. Well, it is. There we go. So again, we don't have ED-based studies that look at the falls patient and hypotension. But in outpatient and in nursing home populations, postural hypotension or postural dizziness are associated with a doubled risk of falls. So, at least from extrapolation, we know that in older patients who come in with falls, orthostatic vitals do have some use. And moreover, pending an actual ED-based study that looks at orthostatic hypotension and falls and answers that question for us once and for all, you should know that measuring these vitals is recommended as standard of care. So the American Geriatric Society and the ASAP Geriatric ED guidelines recommend doing orthostatic vitals as part of your basic falls assessment in the ED. So we'll talk now about how to actually assess walking ability in the ED. I think most of us, myself included, probably write walk test please, well, maybe the please if you're me, on the ED ROT, but I think we can do better. So like I mentioned earlier, we know from studies that asking older patients if they walk well or if they have problems with their gait is not an accurate predictor of objective slowness or unsteadiness. And at the very least, and this is a recommendation from ASAP, you should be doing a gait assessment and watching your patient walk prior to discharge. But what about even more objective measures of walking ability in your older patient? So the timed up and go test is probably the best known and best studied test that we have. Just as a reminder, so the TUG test involves asking a patient to start sitting in a chair, get up, walk 3 meters, turn around, walk back, and sit down. And the numbers for a passed or failed test differ a bit based on what studies you looked at. But in the original studies, a time of less than 10 seconds was great, and a time of greater than 30 seconds was associated with significant mobility problems and a higher likelihood of falling in the next year. So in a study that some people you might recognize performed in our ED, a longer time to complete the TUG was also associated with functional decline, although not self-reported falls at 3 and 6 months. So we know from Dr. Perry and Dr. Eagles that this is a test that's easily completed in the ED, and it's associated with at least one adverse outcome, which is functional decline after ED discharge. Now, you might decide that a TUG test is too structured and too difficult to perform in the ED, although I'll remind you that I just told you that a failed test is 30 seconds. And you might decide that an up and go test, where essentially you just have the person get up and observe their gait, is an easier test to complete. And that's fine too. Basically, what I want you to take away is that actually seeing some of that walk test that you order is really informative. So I thought this would be a good time to talk about our ED-based falls prevention strategy. Now, we have a multi-pronged approach in the ED that starts with the waiting room. Older patients are being asked to complete the Staying Independent checklist, which I mentioned is part of the community ED-based yearly falls assessment. And so they may complete it in the waiting room, and they may bring it to you with a positive screen and ask you what to do with it. Now, this is the Staying Independent checklist, and this is the one from Public Health Ottawa, not the one that we actually have in our Emerge department. It's not been studied in ED, but it's useful as a conversation starter for patients and their families, especially ones who see their primary care provider very seldom, in terms of talking about falls risk. The questions are simple yes or no questions, and 4 or more yeses to this is a positive screen for falls risk. I'm not going to go through all the questions, but I would encourage you to take a look at the checklist when you walk past the waiting room, or it's available online. And the next thing The next thing that I wanted to mention is the next phase of the SETI minor trauma study, which is going to be coming to our is going to be coming to our ED over the next several months, spearheaded by Dr. Perry and Dr. Eagles. So there will be a lot more details when the time comes, but I wanted to show you this new decision rule so that you're more familiar with it when it comes out. Based on previous SETI studies, they've identified 3 risk groups for functional decline among elderly patients who present with minor trauma. And again, these traumas are quite minor. So lacerations, soft tissue injuries, fractures, but all in patients who are going home. So patients will be slotted into low risk, moderate risk, and high risk groups based on their risk factors here. And the resources that are recommended for follow-up of these patients, whether it be outpatient GEM or GEM in the ED, will be outlined based on the risk group that they fall into. And as with so many of our other decision rules being developed, you will also be involved in the validation of this rule. So as Emerge Docs will be asked to complete this rule and identify your comfort with using it. Again, you'll be seeing this algorithm in the coming months, but I wanted to present it to you. I'll give you a minute to read through it. Okay, so we've talked a lot about falls assessment. What I'm hoping you take away from this section, though, is this. Falls are a sentinel event in an older person's life. If you have a person who comes to the ED with a fall, even if they end up in urgent care with a minor soft tissue injury and you're sending them home, especially if it's their first fall, they really deserve a thorough falls workup and follow-up. Things that I can recommend you do based on the ED studies that we do have is to ask about medications, ask about number of falls in the past year, ask about depression and cognitive impairment as well. You should be performing orthostatic vitals. I'm hoping I've convinced at least some of you to start doing them in this specific population group. And you should be looking on your exam at foot care and actually watching your patient walk. Okay, so lastly, we'll discuss pain management in the older patient. Now, as you've just heard, we see a lot of patients in the ED with falls, as well as with other conditions that require analgesia, like extremity pain and abdominal pain. But in multiple studies, it's been shown that we're not good at managing pain in the older patient. Older patients are much less likely to receive analgesia than younger ones. So in one American study by Wong and colleagues, over 1/3 of patients with moderate to severe pain received no analgesia whatsoever. And in another study by Dr. Plassmills and colleagues, they reviewed over 88,000 US ED patients, and they looked based on age at which percentage received analgesia. And as you can see, so the green line, if it projects, is the patients 75 and older on the very bottom, and only just over 40% of them actually received analgesia. So again, our older patients are at a high risk of oligoanalgesia in our emerge departments. And I'd like to stress that this is really something we should be worried about. So I think we have a natural tendency to withhold analgesia in patients who we think might be vulnerable or in whom we have difficulty assessing pain. But unrelieved acute pain is a real concern for us. It's associated with longer hospital lengths of stay, delay to ambulation, a high risk of chronic pain, frailty itself, and delirium. So again, we don't have great ED data for this, but I wanted to discuss a prospective cohort study by Morrison and colleagues from the Journal of Gerontology. So they looked at common risk factors for delirium, and they assessed with a daily confusion assessment method scale the incidence of delirium in inpatients who had hip fracture. And what they found was that in patients who were previously cognitively intact, a single episode of severe pain was a strong predictor for delirium with a relative risk of 9. And that patients, whether they were cognitively intact previously or if they had dementia at baseline, who received the lowest cumulative daily doses of opioids were at the highest risk for delirium. So again, unrelieved acute pain is associated with delirium more strongly than the opioids that you might prescribe to relieve that pain. And you might say that one of the difficulties is that it's hard to actually assess pain in a patient who's really demented and who can't tell you that they have pain. And in Wong's work that I've mentioned, it's demonstrated that we're not comfortable with assessing or with documenting pain in these patients. So less than half of geriatric patients actually had a documented pain assessment during their ED stay. We do have tools, though, to assess pain and to document it even in these difficult patients. So this scale is the pain AD scale, or the pain and advanced dementia scale, which was developed in the US for use in aphasic or the severely demented patient. It's being used in some Canadian EDs, including on the Queensway charting already. And it's recommended by the American Society for Professional Nursing as the standard of care for pain assessment in patients who are demented. So I don't expect you to read over all of it, but all of the components that it deals with are components that we can actually observe rather than having to ask the patient about. And if you're not comfortable with this assessment, then another alternative is the FACES pain scale, which all of us are familiar with on a 0 to 10 scale. And that's the scale that they use on the geriatrics ward here. Basically, though, what I want you to take away is that even though we're not comfortable at assessing or documenting pain in our elderly patients, we do have tools that can help us with this. So when it comes to actually recommending what to use for pain, there are complexities in pain management of the older patient. So older patients have different physiology. They have a leaky blood-brain barrier, so they're more at risk of sedation from the analgesics that we give. And they have decreased hepatic blood flow and decreased renal cell mass at baseline, which means that their metabolism and clearance of drugs will be lower. That said, we do have options for pain management in this population. So again, we don't have ED-based pain management guidelines in the elderly, but I've pulled recommendations from these 3 sources. And for this second reference, I think most of you will have at least heard of the Beers criteria, which are a set of recommendations from the American Geriatric Society on medications that should be avoided in the geriatric patient. So all of these sources recommend acetaminophen and regularly as a great first line. This should really be a go-to, especially if you're keeping someone overnight and expecting GEM and physiotherapy to help disposition your patient in the morning. Tylenol should be written as a regular order on your ROTs. When it comes to NSAIDs, so the Beers criteria strongly recommend against using ketorolac because of its higher ulcer potential than the other nonsteroidals. And they recommend against chronic NSAID use, again, for ulcer potential and other interactions, but they mention that acute dosing might actually be appropriate. So I think we often avoid nonsteroidals in our elderly patients, but according to these recommendations, an acute dose of NSAID for example, a soft tissue injury as part of your foundational analgesia might actually be appropriate, as long as there are no other contraindications to NSAIDs. And for opioids, so it should be clear that for patients with moderate to severe pain, these are our standard of care in the emergency department. Now, drugs like tramadol and oxycodone are metabolized by the CYP system, so their metabolism does decrease with age, whereas hydromorphone and morphine are metabolized by UGT, which isn't thought to be as affected by age. That said, morphine, as you recall, does have active metabolites that have to be renally cleared, whereas hydromorphone does not. Now, despite these nuances, for the opioids, there's no specific recommendation on which opioid to use, but the Beers criteria does say that whichever opioid you choose, you should decrease your starting dose by 25 to 50%. Now, for tramadol, which seems, I think, to be a go-to for us for moderate pain, there's a recommendation, again, in the Beers criteria to decrease your starting dose by 25 to 50%, and then to avoid it in patients with renal dysfunction, on serotonergic medications, with a history of seizure disorder, on anti-seizure medications, or at risk for hypoglycemia, as there are retrospective studies that have found an association between hypoglycemia and tramadol use. So I can't recommend against it because none of the associations have outright discouraged it at this point, but the side effects, especially in our elderly population, really do seem to be stacking up against it. And of course, so our non-pharmacological measures and our local analgesics are ideal. So for example, with our femoral nerve block study or with the fascia iliaca blocks as appropriate for hip fracture. Okay, so for pain management, I'm hoping that you'll recognize that we can assess pain, and we do have validated scales that'll help us assess pain in our demented patients, and that unrelieved acute pain is actually worse for delirium than prescribing a lower dose of opioid to these patients. So we shouldn't be so afraid of using opioids for patients who have severe pain in the ED, even if they are elderly. And if you're going to prescribe opioid, then especially for your elderly patient, don't forget a bowel regime. Okay, so lastly, before I wrap up, I want to talk about some of the feedback that I've gotten from our GEM colleagues. I think there are ways that we can refer better to GEM so that they can do a better job of assessing and referring patients to the right services. So you've all seen the referrals form from GEM, but we're going to go through it again. As you know, GEM is really happy and specifically trained to see patients with the following issues. So despite this 1-hour talk, they are much better than us at assessing concerns with memory, delirium, mobility, concerns with mood and anxiety, and concerns with personal care or with medication compliance at home. But in order to properly refer these patients for assessment of these issues, we need to meet a few prerequisites before the referral process even starts. So patients need to actually live in their own homes or in a retirement home. They cannot come from a nursing home. And really importantly, they need to be medically cleared with a plan for discharge. So the feedback I've gotten is that sometimes we refer patients who end up having significant medical issues which necessitate admission, or they may not even be able to walk, period, and we see that all the time, that patients need admission because of mobility. So ideally, you will have cleared your patient medically, and will have walked the patient to make sure that their mobility does not prevent them going home. So what this means, especially if you're keeping a patient overnight, is that they've got regular pain meds, as we discussed, and that they've already had a trial of ambulation. So again, GEM can't walk your patient for you. You need to do it. And this way, GEM will be able to liaise with all the appropriate outpatient services that they're so good at referring to, instead of having the patient kind of lost to follow-up as they are admitted. So in terms of take-homes, I'm hoping that after this you'll recognize that frailty is an independent syndrome which has very high morbidity and mortality associated with it, and that we have tools to start recognizing it in the ED. For your falls assessment, so really importantly, actually watch your patient walk. And maybe some of you will start measuring those orthostatic vitals. And for pain, don't be afraid to explore your options, including opioids. These are my two 88-year-old grandmas. This is from when they were maybe like 85. And I thought about them a lot in preparing this talk, especially in the context of our hospital motto, which is here. I want to thank everyone who helped me prepare this presentation. So Dr. Eagles, who is my supervisor, who provided her immense knowledge base on the literature around these topics. Dr. Perry, who is very helpful with all of the study literature and what's to come. Dr. Kitty Clare, who is one of our geriatrics fellows, who very graciously reviewed my slides with her the week of her Royal College exam. Ioana Genovesos, who is with our GEM colleagues, the GEM manager, for all her expertise and feedback. And Carrie Poulin as the nurse educator at the Civic here as well for reviewing my slides. And Scott for actually watching, as well as many of my other friends who were actually willing to sit through this twice. So thank you, and I'm happy to take any questions.